carry his entire weight. I am not lifting him up from the floor, but I try to take most of his weight. And then I turn around the paw in this position, and I want to see a correction right away. So, if that happens, the question is it real? So I repeat it a few times. Yeah? I'm afraid I have to tell you it's not normal.
Of course.
Yeah, so I didn't expect that now. I wasn't expecting a normal, but that's the way it is. That is abnormal. Even when he did finally correct, it was much too late. So it should be from the time frame, I turn it around, and in a second, very maximum in a second, you should see the correction. But as I said, repeat it a few times, and it's abnormal. Now, where does that information go to? It starts in the receptors, it comes up the peripheral nerve, it goes along the spinal cord to the brainstem, to the other side of the forebrain, sensory cortex, from there to the motor cortex, and there is the response generated, and the answer comes back all the way, and it's turned around. What does that mean? It means that we are testing more or less the entire nervous system. So if the proprioception, or some people call it the paw positioning, is lost, we know it's some disease of the nervous system, but we do not know at all where it is all along that way. I believe it's important.
Pyramidal track.
No, actually the pyramidal tracks are less important than they are in other species. So it's not the pyramidal track. The pyramids are ventrally, the proprioception is dorsal in the spinal cord and in the brainstem. What is important if you perform that test is that you really place the paw in exactly the position where it belongs to. So don't place it here, don't place it here, because you are stimulating many other receptors. Just place it in a position where it actually belongs to. One more thing. Don't grab the entire leg and do something like that. Again, you are stimulating many receptors. And if you have mild deficits, you may not see this. What I usually recommend is carefully just take the digits, turn them around. In this dog, it doesn't make a difference if you do it that way or if you are slowly and carefully, but in dogs with minor deficits, it makes a difference. Yeah? So let's see what the other side says. So that's what we actually expect. Yeah. Might still be maybe slightly delayed, but there is a left-right difference. We have to keep that in our mind. And that's always a point where we have to start to write things down, because we may not know in 50 minutes anymore that it was much worse in the left than in the right. Front limbs, the same thing here. It's okay. I usually have my hand here to support him, and that prevents him from running away. Yeah, so I can actually fix him a little bit. Okay, that looks pretty good. Oh, big boy. It works easier on the floor. So probably the limb that is definitely affected is the left rear. I said before that we are more or less testing the entire nervous system, and I cannot say if you lose your proprioception in this one limb where the problem is. However, if I take together now that probably this limb is affected and maybe not the others, I can narrow down the neurolocalization, because the tracks for the proprioception for the front limbs, they go to the spinal cord, and from here onto the brain it's the same way as for the rear limbs. So obviously everything here is working. meaning that if only the proprioception is lost in one real limb, the problem is either in the peripheral nerve here or in the spinal cord up to T2.
Do you think this is normal?
We probably should do it on the floor to say for sure, but just for demonstration, if we assume it's normal, to be sure we should do it on the floor. So, I said before, proprioception does not help us to localize, but as you saw now, if it is only affecting one limb, or even if it would be both real limbs, but the front limbs would be normal, we would say from here to here everything is normal. It has to be somewhere in that area. So ideally we would do it on the floor, but nobody of you would actually see anymore what we are doing, and we could combine that with hopping, as you have seen, or some of you have seen in the video yesterday, but hopping doesn't work on the table. Yeah. Okay, King. Now you have to turn around. You're bored, yeah, I can see that. Maybe we move over here now. Can we move to this table, please? Okay, and maybe if you can stay here and hold him a little bit. No, I can actually take the head. The next thing I usually do is testing the cranial nerves. And when we test the cranial nerves, we want to train ourselves all the time that we keep in mind what are we testing there. So if we perform a test, I ask myself, which structures am I testing right now? And I usually start with a Menace response. So even though it's a big guy, I usually grab the mouse and the nose, it's okay. And with the same hand, I cover one eye. And then we make that sudden movement, and the eye is supposed to be closed. Some dogs don't close their eyes just because they don't believe that the hand is really coming. And what we can do in those, we just touch the eyes a few times, and then we perform the test again. Yeah. What was the age when you would be?
3 months.
Yeah, 3 months, it should be there. Which anatomical structures are we testing there? Yeah. So everything I have heard was correct, but maybe let's start in the order how the information gets into the brain. The very first thing, the eye actually, then the optical nerve, it goes to the brainstem, then to the forebrain. On which side? If I test, genau, the opposite side, yeah, and then the response comes back, and the facial nerve is closing the eye. And then we do the other side. And it works pretty well. Yeah? If we are here with vision, the other thing we could do is a cotton ball test. Let's assume for a moment that that is a cotton ball. Yeah? Why a cotton ball? Because if you just take a little piece of cotton ball, it doesn't make a noise. So if you drop something and it makes a noise when it hits the table, the dog may actually hear what's going on, it may follow the noise. But what we want to test with a cotton ball test is the vision. That's why it should be something, it doesn't have to be a cotton ball, but something that doesn't make a noise during dropping down. And we can take a little bit of that paper, and as I said yesterday, ideally the person testing is standing behind him. You have to concentrate on our business here. Yeah, and if you may have seen that, yeah, and repeat it a few times if that is repeatable, and do it laterally. Don't do it in the middle because of the overlapping of the visual field. It obviously works. Yeah, so it's a very rough, or no, rough's not the correct term, a general testing of vision. I'm not sure if one of you has been to a, how do you say in English, optometrist. You look in some apparatus and you get those lights that's coming up there and there and there, and then you have to hit the button all the time. And they test the visual field if you have deficits in a certain area. That's something we cannot do with our patients. So it's more a general question, can he see? And I would really not rely on the owner's description or on the fact that he is not hitting any objects. It's interesting how well patients can orient without vision. Canine patients. So we should really test that, and the cotton ball test would be another thing. Then we come to the pupillary light reflex, and as I said, the most light sensitive area is lateral on the retina. So most people I see test the pupillary light reflex that way, and if you come from lateral, you hit the medial part of the retina. We want to do it the opposite way, come from the nose and direct the light laterally. Okay, so we do that now. And the pupil is constricting, and then I go slowly, go fast to the other side, and I want to see the other pupil constricting as well. It usually constricts less than on the side where you shine in the light. So don't be surprised if this pupil does not get the same size as this one, but there should be some response. Again, what are we testing there? It starts with the eye. Optic nerve first, optic chiasm, then goes to the brainstem. You could name those nuclei, but it's not really necessary. And the parasympathetic fibers of the oculomotor nerve. It does not require function of the forebrain. So a dog that has a normal pupillary light reflex can still be completely blind. Or to turn it around, if I have a patient where I get a normal pupillary light reflex, but he does not have any Manners response and he does not respond to any cotton ball test, we know that this dog is blind, but we know that the eye is functioning because it has a pupillary light reflex. We know that the optic nerve is functioning. We know that the optic chiasm is functioning. So the conclusion is we have a blind patient with a normal pupillary light reflex, that the problem is in the forebrain, just in the visual cortex. It's just not generating any picture there. Okay.
Central blindness.
Central blindness. Yeah. The next one would be the palpebral reflex, and quite often people do it the way I show you. You can see what happens. He's already blinking before I touch him. Yeah? So, in my opinion, we should come from the top because then he cannot see the instrument, and we slightly touch the medial and the lateral part. And here's the response is usually better in the medial part comparing with the lateral part for the reasons we don't know yet. Which anatomical structures are we testing there? Whenever we touch the patient somewhere in the face,
Facial nerve.
trigeminal nerve.
Trigeminus.
Yeah.
Nerve
Then it goes to the
it's sensitive tract and affect tract facial nerve.
exactly. Yeah. So what else can we do? Nasal sensation. It's a similar story. I want to touch his nasal septum, and it might even be for him it works, but some dogs already pull the head away when they see the instrument. So we are not testing vision here. That's why it's important that we cover his eyes. And now we slightly touch. Can you lift up the head a little bit? Yeah, thanks. And the response is not just that he does something with his nose, he usually pulls his head away. And that's important because in order to pull away your head, you have to use your forebrain, you have to initiate a motor response. Why is that important? Because for the palpebral reflex, that's a pure reflex. The information goes to the brainstem, the patient is not thinking about what happens, and you get a response. In order to pull your head away, you need more than your brainstem, you need your forebrain. And I generated that example yesterday. We could have a patient that has a normal let's get one step back. Which anatomical structures are we testing with a nasal sensation? Sorry? The trigeminal nerve, that's the sensory part. Brainstem, forebrain, exactly. So if you have a patient with a forebrain disease, what can happen is that we have a normal palpebral reflex. So we know that the trigeminal nerve is working, but when we test the nasal sensation, he does not respond. So we know the trigeminal is functioning. That means the only explanation is the forebrain disease. And I've shown an example of a cat yesterday, especially if you have a left-right difference. That's very convincing because you have the other side as a control. This animal would respond, but it does not respond on one side. Corneal reflex. Yesterday on a video I have taken a Q-tip. Quite often I just take my fingers. Important is really it's a corneal reflex. You are supposed to touch the cornea. It's not about the eyelids. So you have to open it up. I usually take 2 fingers, open the eye, and then I carefully touch the cornea. What I want to see is the retraction of the eyeball, or sometimes you do not see the retraction itself, you just see the flip of the third eyelid. What are the anatomical structures we are testing? Whenever we touch the patient in the face, it's the trigeminal nerve. Now, when I say that, now we get to the next level. That's not entirely true. The inner part of the ears are not only innervated by the trigeminal nerve, but by the facial nerve and the vagal nerve as well. But if you exclude the ears, then whenever you touch the patient in the face, it's a trigeminal nerve. Do you have to know those nerves? No, you don't have. You have just to perform your steps. And if you find one deficit in one of those tests, then you have to open a textbook or go to the internet. Which anatomical structures did I have tested right now? And then you know where the deficit is. So now I'm explaining all this, you don't have to remember the nerves. You just have to work yourself through the checklist you have in order not to forget any nerve. And if you find a deficit, if you don't find a deficit, it's fine. Then you don't have to care about the structures you have tested. But once you find a deficit, you have to see which structures are involved. Okay. The next thing would be the physiological nystagmus. Physiological means I move my head and I should get that interrupted eye movement. Why does that happen? If I would move my eyes with my head at the same time, I would get that blurry view if you look out of a car window or of a train, because our brain is not able to process so many pictures in a short period of time. So what our brain does is when we move our head, it keeps our eyes focused on something, takes a picture, and then the eyes follow the head movement, next picture. And that's why you get that rhythmic eye movement. It's just because the brain cannot process all the information if something like that would happen. So that physiological nystagmus should be there. So we move the head to the left and to the right. And if the eyes are really moving the correct way, you can easily see if you lift up the eyelid so that you see the sclera. At least those of you who sit in front of him probably see the movement. It's easier than without lifting up the sclera. If you see the white, it's much better. Yeah? What structures are we testing there? The vestibulocochlear nerve, that's the sensory part. Sorry? The oculomotor. We need two more nerves now.
4, 5, 6,
but you are very close to it. Could I maybe get that paper there? Because I will show you the solution of what I said yesterday about those 3 nerves. Do you remember the sulfuric acid? Let's write it down once more. LS6, SO4 times 3. It looks a little bit similar. It's a chemical formula for sulfuric acid. LR6 SO4 times 3. And there are 3 numbers in there, 3, 4 and 6. And those are the 3 nerves that innervate the eyes and can pull them in any direction. So oculomotor nerve, the trochlear nerve, and the abducens. Now, that's only part of the story. Those letters can tell you which muscles are innervated by those nerves. I make a drawing and I show it to you. If you look at the eye, here's lateral, here's medial. So we just look from the front onto the eye. We have 4 muscles that pull in any direction, and we have 1 oblique muscle on the bottom and 1 oblique muscle on the top. Yeah? That's the eye. Here's medial, here's lateral. 4 muscles that pull in any direction, and 1 oblique on the top and 1 on the bottom. Now, using this formula now, LR, it's a lateral rectus muscle. That is the one that pulls laterally, is innervated by the 6th nerve. So, LR6 lateral rectus, yeah, it's okay. The one that is pulling laterally is innervated by the 6th cranial nerve. SO stands for superior oblique. That is this muscle on the top. Is innervated by the 4th cranial nerve. SO, superior oblique, is innervated by the 4th, by the trochlear nerve. And all the other muscles that are left are innervated by cranial nerve 3. So if you move that head in a certain direction and you do not see any rhythmic movement in some direction, you can use that formula to see which muscle is not working and which nerve is involved. You don't find that in any textbooks. So that's more or less a story I made up. So you have to memorize this because you will not find it anywhere else. LR6, SO4 times 3. So if he does not have that movement in any direction, then either the vestibular nerve is not telling him that he is moving, or one of those nerves pulling in one direction is not functioning. The superior oblique, innervated by the 4th cranial nerve, that's the muscle that's actually rotating the eye. You can easily see in a cat if that nerve doesn't work, because they have that slit-like pupil. If that is rotated, it looks abnormal. In a dog, that's getting difficult because they have a round pupil, and the only way to recognize this is if you look at the back of the eye. If you are somehow familiar how the blood vessels should be located there. They have a certain order how the blood vessels look like, and if this is rotated, it probably means it's a trochlear nerve problem. So much about the physiologic nystagmus. The pathologic nystagmus is obviously if he does not move and if you see a nystagmus. So again, lift up the head and observe him. Right now he's looking around. We want to see if there's any rhythmic that repeats again and again. And as we said, it can be either in the horizontal plane or it can be in the vertical plane. And the fast beat can go up or down, it doesn't make a difference. Or it can rotate around the long axis. And one of those types of those 3 is only seen with central vestibular disease where the problem is in the brain. And which part was that, or which type of nystagmus? The vertical. So if you see vertical nystagmus, it means central vestibular disease, brain disease. If you do not see, you're actually a nice guy, yeah? If you do not see a pathological nystagmus in a normal position, I usually lift up the head and see if I can induce nystagmus. And if that is not enough, I turn him on his back, as you have seen yesterday in that one cat. Yeah? Okay, have we done everything about the cranial nerves yet? I believe we are through with the cranial nerves. The next step would be segmental spinal reflexes. And for that we have to put him on his side. Maybe with the feet to us. Yeah?
Okay.
I'm a nurse in this hospital.
Okay. So I go to the rear limbs first. It's okay. It's okay. So before I actually start to do the reflexes, I'm flexing the limb to see what the muscle tone looks like. You have seen that on one of those videos. Is it just flaccid or is there a normal muscle tension? And then we have the reflexes we did talk about. And the first one would be the patellar tendon reflex. For all those reflexes, it's important that you think about which part is supposed to move. In a patellar tendon reflex, the knee is supposed to be extended. And if that is the case, you cannot hold the limb here, because then you restrict the movement. So support the weight proximal of the part that is supposed to move. And for the patellar tendon reflex, you can just support the femur very well. And then it's about the patellar tendon. And as I said, if you have a tendon reflex, take the wide side of the hammer, and usually it only requires a mild stimulus. Yeah. And you want to see an extension of the knee. Is that normal? What do you think? It's brisk.
Need to check on other side.
Yeah, we can check the other side. For neurolocalization, I said it's important, in my opinion, if it is reduced. Is it reduced?
No, probably not.
No, probably not. And you see my point from yesterday. It's sometimes very difficult to say if it is normal or increased or brisk. It's much easier to decide if it is reduced. Yeah? So lift it up from the floor. What should not happen, that it's gets stuck here because then it cannot move. Lift it up so that you can really see a free movement, and then only a slight touch. The second thing would be the craniotibial reflex, that's that thick muscle here. And the expected response would be a flexion of the tarsal joint, meaning you cannot hold the limb here, but you can easily take the tibia, because then that part can move. Now it's a muscle reflex. We turn the hammer around and take the tip. And remember when I did that, some mild hit is enough. If we have a muscle reflex, I really have to use some power, and we get a response. The question is often how hard do you have to hit the muscle? You can try it on yourself. Not for the rear limb, but for the front limb. We have an extensor carpi reflex too. There's one difference. In humans, we have muscles for every single finger. So what will happen now, not that I move the entire carpal, but you will see that the finger is moving if you hit the right spot. And you can test on yourself how hard do I have to hit it. Don't do it too often. I used to do it for students many times, and then the next day I felt something was wrong with my finger. So you can somehow injure your nerve, obviously. So, okay. So you need a little bit more power for the craniotibial reflex, and that's a normal response. Which nerve are we testing there? The sciatic nerve, and the sciatic nerve did originate from which spinal nerve roots? 6, 7, and sacral segments. Everything that starts with an S. What was it for the patellar tendon reflex? Which nerve did we test there? Femoral. And the femoral nerve comes from nerve roots 4, 5, 6. 4, 5, and 6. And the other reflex we are commonly testing is the flexor reflex. It takes the skin here. Sometimes it's just enough to take your fingers this way, but sometimes I really take the skin between my fingernails if I require more stimulus. And I really see how well can he actually pull. So I want to see flexion of all joints, hip, knee, tarsal joint, but I want to see if it is an appropriate strength. So it's not enough just to pinch it and to see that he is lifting up. You should really hold it and see what is the strength. It's a dog with a lot of muscle. There should be some power behind. So even if the dog would feel what happens and is flexing, but the strength is reduced, then it can be abnormal.
Test medial and lateral.
Like we would have arranged that discussion before, because that would have been my next comment. In general, we say the flexor reflex, there is the sciatic nerve responsible for that. That's not entirely true, because there's a difference if you tested medial and lateral. The lateral 3 digits are innervated sensory by the sciatic nerve. So if I pinch here, the information goes up to the spinal cord through the sciatic nerve, and the response comes back through the sciatic nerve. If I take the most medial digit, the sensory input goes up through the femoral nerve, and the response comes back through the sciatic nerve. So if you have a femoral nerve lesion, or in the area, a lesion in the area of L4, 5, 6, what can happen is that you do not have a patellar tendon reflex, and you do not have a flexor reflex if you pinch here, but you have a normal flexor reflex if you pinch here. Okay. There was one more thing I wanted to say. It's gone. Okay. Then I move to the front limbs. I usually only test 2 reflexes.
And when you reflex it, when you flexor, and you have the extension of the other.
Okay.
Right? What
Yeah.
this means?
You're referring to the cross-extensor reflex. Yeah. If you perform a flexor reflex here and he is flexing his limb at the same time he's extending this limb, that is an indication of a spinal cord lesion higher up than the segments at 4. So I wouldn't say, as you may read in some textbooks, that's a prognostic negative indicator. I'm not sure about that, but it's a sign of an upper motor neuron lesion, to use that word. Yeah? So a lesion that is higher up than the segment where the nerves take off to innervate that limb. Usually those patients have severe neurologic deficits. So it's, what will not happen is that you do an examination in this dog and you incidentally, unexpected, find a cross-extensor reflex. So it's usually a sign of severe disease, and those are dogs that are not able to walk in the majority of cases. But I do not believe that you can base the prognosis on that. Now I remember what I wanted to add. Sometimes the patients are very scared and they are laying here on the table, the limb already flexed and it is so stiff you cannot test any patellar tendon reflex. Usually the lower limb is much more relaxed. So an alternative would be to test the patellar tendon reflex on the lower limb. And quite often it's much easier there in dogs that are very scared. So if you do not get the reflex because the dog is very tense, try it on the lower limb, but if you turn it around again, then you test that side. Okay, coming to the front limbs. I usually test the extensor carpi reflex and the flexor reflex. Extensor carpi, as the name says, the carpus is supposed to extend. That's what I did demonstrate on my own arm. And in order to be able to extend your carpus, you cannot start that way because it's already extended. You have to flex the carpus. And if you do it that way, it's hard to flex that carpus. But it's easy if you flex the elbow. then you automatically flex the carpus. And so flex the elbow and start that way. Again, lift the limb up from the floor. If it is laying here, you may not actually see that mild extension. Lift it up. You can hold it in the radial area, and it's this large muscle belly here. You have to hit the muscle belly again, meaning you take the tip of your hammer and you need some power again. And sometimes you have to find the exact spot where it is and move around here. But that's already appropriate response. It's a radial nerve that is responsible for that, but because there is much overlap in the innervation, we do not try to localize that to specific nerve roots. We should just know that all the nerves innervating the front limbs are coming from the spinal cord segments C6, T2. The way I tried to memorize when I had to learn that once was that in the middle there is a piece that goes from 3 to 3. T3 to L3. And if you know that, you already got it's number 3, grade 3 in the exam. Because you know half of it. If you know that it goes from 3 to 3, you know here it starts at L4, and you know this one ends up at T2. So that's shown, you already know most of it. So start with the T3, L3 area. Extensor carpi reflex. A colleague of mine, he really likes the biceps reflex. I just try to demonstrate that, but in my opinion it's not a very reliable reflex. You have to hit the biceps tendon. It's very difficult to hit it here. You may have to come around if you want to. It's very difficult to hit it. So what you have to do, you have to put your finger on the biceps tendon and you have to hit your own finger. That's only one reason why I don't like it. Yeah?
That's why I see some doctors have bruises on their nails.
And the response, you see actually the contraction of the muscle here in that area, if it works. Yeah? So it works in this dog, you could see it here. I don't like it. So I rely on the extensor carpi reflex and on the flexor reflex. Same story. I take the skin here and I see if there is enough strength to pull. And if I compare the strength here with the same rear limb, I believe there's a little bit of discrepancy. Yeah? I mean, there's even more muscle here. So if I compare that now, I probably would say that the reflex in the rear limb might be slightly reduced. It's much stronger here in the front limb. So you can use the left-right comparison to see what is normal, or you can compare a little bit front limbs against rear limbs. Okay. Can we turn them on the other side to see how that looks like?
Wait.
Okay, let's start with the rear again. So, see what the muscle tension is here. And it somehow subjectively looks feels a little bit better than on the other side. Patellar tendon reflex. It still looks brisk, but for neurolocalization, as I said, look for reduced reflexes. Which nerve, which spinal cord segments? Yeah, L4, but I would narrow that down further. You are right, L4, S3, but within the L4, S3 area, we can narrow it down further since it's a femoral nerve and that comes from 4, 5, 6. Yeah? Craniotibial reflex, the thick muscle belly here, the tip of the hammer, more power, and we want to see a flexion of the tarsal joint. And that's a normal response. Yeah. How do I know that it's normal? yeah, you have to do an exam a few times on normal dogs to see what normal is. You have to believe me that it's normal. Yeah? Flexor reflex. And yeah, that looks better than on the other side. Yeah? So especially if I compare those now, I would say that on the left side the flexor reflex is reduced, and we have to keep that in mind. Extensor carpal reflex. Flexing the elbow in order to flex the carpal joint. Muscle belly reflex. Tip of the hammer. More power. And there's a pretty good response. I'm not sure if you have seen that, but
Yeah, I see.
yeah.
Trust me.
Radial nerve, flexor reflex. Yeah. So much about the segmental spinal reflex. Segmental spinal reflexes of the front limbs test the area. Let's repeat it once more. C62. Segmental spinal reflexes of the rear limbs are testing the area L4, S3. Yeah? Okay, so at the very end we are testing the panniculus reflex and spinal pain. So for that he has to get up.
Wake up. And I will see how it goes.
Okay.
And sleep. Okay.
So I believe it's helpful if they are standing. So I just have my hand here in order to prevent that he sits down. As I said, I will be pinching the skin here. It's not in order to elicit pain, it's just stimulating the skin. Some people take a needle. I like to use those hemostats as well. And the information goes into the spinal cord, it travels up to the lower cervical spine, and there the nervus cutaneus lateralis is leaving the spinal cord and is innervating the skin muscle. And this reflex in many dogs, or most dogs, does not exist caudally of the cranial part of the iliac wing. So you can feel the iliac wings here. There's no need to test it in the caudal area because it just doesn't exist in most dogs there. So we start somewhere at the iliac wings, paramedian, and we pinch the skin to see if the muscle is contracting. I'm not sure if you have seen that. There was no response, no response, no response, and here it did start. If something like that happens, I try to see if I can repeat that. Yeah? So I start again. Seems to be the same point. The spinal nerves are not going into the spinal cord in a rectangular way. They go 2 vertebral bodies further cranially. So if I have a cut off here, if he has a problem, it's about 2 vertebrae further cranial. Yeah? And where are we? This last rib is here. That might be about T13. So we have to keep that in mind, that there is a cut off behind T13. Let's see how the other side looks like. Again, we start at the level of the iliac wings. Here there's some response, and there it's getting better. It's pretty much the same area.
On the beginning,
Yeah.
it's a little bit pressure. After that, less.
I believe he can feel it, but he cannot really twitch, as my impression. Yeah? So he tries to go down because he can feel it, but there's no appropriate twitch of the skin muscle here.
Absolutely.
Yeah, and there it starts. That will be a little bit tricky for neurolocalization in a moment. Okay, and the last thing is testing pain. I usually have them in a standing position. I have one hand underneath, and then I press on the spine. I start it very slowly so that it feels like a massage, that the patient becomes used to it, that I'm touching there. And then I slowly increase the pressure. And I want to see, either I feel how the muscles are tensioning here, or he is or she is turning around or is yelping. So I slowly increase the pressure. More. So I really press hard at the end. Yeah. If I get to a point where this dog is responding, then I try again to see if I get to the same point. And if I get to the same point, I start at the opposite end and move in that direction to see if I can really narrow this down to one specific area. If he responds one time here, and one time here, and one time here, it probably just means that it's too much pressure for him. Yeah? I want to have one focal point usually. As I pointed out yesterday, in the neck we have so many muscles, especially this dog, that pressing here will not elicit any pain. So what I do for the neck here, I show you that I step on your feet.
Sorry, you will not smash me, don't worry.
So I try to flex the neck, and usually you can put the chin on the chest muscle without any resistance. And then I lift up the head. To have about a degree of angle of 90 degrees, and that works pretty well. And then I turn the nose around, both sides. If this dog would be painful in the neck, especially with that amount of muscle, he would resist and he would not be able to turn it around. So now there is no pain. What I sometimes do in dogs with lumbosacral, with suspected lumbosacral pain, I lift up the tail to see if that is painful. And in addition, I may even do a rectal palpation. So I go in and I press at the lumbosacral junction from ventral to see if that is painful. So much about what I would do for neurological examination. Which deficits did we find in this dog? He definitely had reduced conscious proprioception in his left rear limb. He did have what I would consider a reduced flexor reflex in the left rear limb. And he has a planiculus cutoff somewhere around T13. That was probably his deficits. Let's go through the neurolocalization. Or do you have questions?
Yeah, it would be interesting if this dog to do the lateral and medial and the flexor reflex, because it would differentiate between the sciatic and the femoral.
Yeah, I actually thought there wasn't any real difference when I did it. Yeah.
That means you've got two areas.
Sorry?
That means you've got two areas near.
Let's go through that, but do we believe this dog has a neurological problem? Sorry?
I didn't believe, but now I can see
Yeah.
that. Okay.
Why?
Normal appearance, normal walk.
Because you didn't ask me.
I thought you said you believe he has a neurological problem.
Right now.
Yeah,
yes.
but why do you believe?
Reflexes.
Yeah, the reflex, that's my subjective assessment. I could be wrong, but what we cannot ignore is the proprioception. So, just based on the proprioception, we know it's a neurological problem. In order to localize it, we said the next point could be to ask ourselves, could that be a problem of the peripheral nervous system? And I told you two strong criteria. Do you remember when we consider a peripheral nervous system disease? Either only one limb is affected, or all four limbs, and reduced motor function in all four limbs, plus what would we have? Reduced reflexes in all four limbs. Does one of those criteria apply to that dog? The first one could be, if you ignore for a moment the panniculus reflex, it could be a problem in the peripheral nervous system of that one limb, and we can even narrow that down further to one nerve. It was a flexor reflex that was reduced, so it's somewhere in the area of the sciatic nerve. Yeah? What does not fit with it is a panniculus reflex. And now it gets probably a little bit tricky. If we say this dog has a bilateral loss of panniculus reflex, and that is based on a spinal cord disease, it would be very unlikely that that's the only thing we see of a lesion here in that area. So we would expect to have something going on in the other rear limb as well. So it's a true finding, but at the end of the story, you have to ask yourself which findings make sense. Now I believe what is very reliable is what happens in the left rear limb. I cannot explain the panniculus reflex, but I do not believe that that is related to the rear limb. Whatever is causing that, maybe it's one of those dogs that just does not have one further down. They exist. So I would say most likely, yes, he has a problem in the peripheral nervous system of his left rear limb, probably in the area of the sciatic nerve. My understanding is that we do not know the history of that dog. Is that correct? So we do not know what
He seems to have injuries on the.
Yeah, but he has on the other side.
And it has pressure source on
Yeah.
all
He had
point
4
pressure.
decubital wounds. He was completely neglected. He is Ehrlichia positive.
Okay. So I don't believe that it is an Ehrlichia infection. It would be more generalized. It can affect the nervous system, but it probably would be more generalized. But since we do not know what happens there, it's difficult to say. But yes, he has a neurological problem, and it's probably in the area of the sciatic nerve. One explanation.
Is it possible to narrow down which part of the sciatic nerve?
No. No. That could be evaluated further by electrodiagnostics. So I'm not sure if you have heard about electrodiagnostics, where you take measurements of electrical measurements of the nerve to see how fast it's transmitting, and you can actually take measurements in different areas of the nerve, and that may allow you to say which area is affected.
Or histopathology, alternatively.
Has he had any injections in his nostrils?
That's exactly what I wanted to point out. What can happen sometimes, that with some injections in that area, you may cause exactly those deficits we see here. So if that happens after an injection, that could be very likely the explanation, but we don't know if that are.
His
Not in
patient.
last 10 days, for example.
His patient.
So if that would not be your dog from the hospital here, but the client's dog that came in now, what recommendation would we make? Sorry, wait and see. Yeah, that is an option. It depends a little bit on the history. If the owner has already reported that there is some problem and it's getting worse, then we obviously would do some diagnostics. And the most likely differential diagnosis for a chronic progressive paralysis of one limb is, sorry? Yeah, it's a nerve sheath tumor. And for those tumors, it's important to catch them as early as you can, because they have the tendency to grow into the spinal cord. And once they have reached the spinal cord, there's nothing you can do anymore. But as long as they are outside of the spinal cord, you can save that dog by amputating the limb. Yeah? So in those patients, the earlier you get it, the better it is.
So what's better, CT or MRI?
For nerve sheath tumor.
Yeah.
If you ask a neurologist, the answer is all the time MRI.
But high field.
But especially nerve sheath tumors, you may quite often see on the CT scan as well. Yeah. But in general, to say, did it already reach the spinal cord, for instance, you're not able to say that based on the CT. On the CT, you see the mass, and you say it's a nerve sheath tumor, but you do not see how advanced the problem is. Okay, for this dog with an unknown history, it probably may have had some trauma to the nerve, I would say, and wait and see is probably a pretty good option.
Because the owner didn't know.
Yeah,
They didn't
exactly.
tell us.
Yeah. So it's probably not a progressive problem that becomes all of a sudden.
So
Okay.
that just brought up a really interesting question, which I don't really know anything about. But you said high field and low field. So we're kind of restricted here because we have lots of bells and whistles, but we don't have them all. So what are our restrictions with low field MRI versus CT? How do we make our decision for our patients of which modality we need to be using?
Does the question go to him or to me?
Either of you,
Do you-
you kind of.
Please. please help me with this answer.
There's probably no structured answer now, but I try to make a few comments. Many spinal cord diseases, compressive spinal cord diseases, you can diagnose on CT. In my opinion, as long as you inject subarachnoid contrast. Many people do plain CTs, and that may be working for some disc diseases, but in my opinion, you see much more if you have injected subarachnoid contrast. Everybody can do that. If you train yourself, it's not very difficult. But what CT does not tell you at all is what's going on inside the spinal cord. So all diseases that affect the spinal cord itself, inside, you need an MRI. Having said that I have to admit that especially low field MRIs have difficulties to show details under two circumstances. And that's on one hand, very large breed dogs that have.
We have big coil, much. At least
but
these
usually
dogs we can.
the signal does not really go deep into the patient. So the quality of low field MRIs is best in a mid-sized dog. The other problem is very, very small patients, because in order to get a good MRI image, you have to have a certain amount of tissue, we say a slice thickness. So the way MRI works is you initiate some impulse to tissue, and the tissue is responding. And the more tissue you have in your slice, the more response you get. However, if you say that we take slices of 3 or 4 millimeters, then you can see if I take slices in a spinal cord of a cat that is 4 millimeters thick, then I only get one image of the spinal cord, and I may miss details. So very small patients are a problem, and in my opinion, very large patients are a problem.
Even if not properly localized slice on the middle, on localizer, you might skip spinal cord in 2 images.
Maybe to answer your question a different way, if your first differential diagnosis is intervertebral disc disease, you do probably pretty well with CT and subarachnoid contrast, because you will find anything that is compressing the spinal cord from outside. But if you do not find anything there, then you have to consider other differentials, and then you may need actually MRI.
Better to do both.
Better both. I do.
It's better for us.
And I mean, we have in our hospital, I have the possibility to do a myelography, and at night, since we don't have MRI at night, I usually start with a myelography. Some people say that it's not up to date anymore, that I totally disagree. It's a valid procedure. And if that does not give an answer, I do a CT. And I see anything that is compressing the spinal cord, so anything that has to be addressed on an emergency base. I'd say not anything, but 90%. But all the other diseases, especially those that are inside the spinal cord, you will miss with a CT. You need MRI. And yeah, it's better to have a high field MRI, but that's complaining on a high level, to be honest. Yeah? 20 years ago, everybody was, maybe even 10 years ago, everybody was happy to have a low field MRI, because we started to make diagnoses we have not been able to make before.
20 years ago, we was happy to have conventional X-ray.
Okay, yeah. And in 20 years from now on, they will laugh about us and say, how could they even try to make a diagnosis with an MRI? Yeah, that's just the way it develops. But
So going back to your nerve root tumour, then.
a nerve root tumor you would see on a CT.
Cat.
Cats, luckily enough, rarely get nerve root tumors. Yeah. It's usually the dog, and you will see it on CT, but you will not see if it is already invading the spinal cord. For that you will need MRI. So if the owner let's say you did a CT and you diagnosed a nerve root tumor, if the owner is interested in surgery, which usually means amputation, then you should do an MRI first to see if it is already in the spinal cord, because then surgery doesn't make sense anymore.
Okay, I may a little bit simplify your task. Okay, sometimes, for example, we work closely with Dr. Ruben. If you have any doubts, feel free, just contact me and we will find optimal solution for some particular case. If it is intracranial lesion, preferably we can advise MRI.
Yeah, definitely.
Yes. If it's spinal lesion, we can decide if it is medulla problem. Maybe we will choose, depend of size of the patient. We will choose optimal solution. Sometimes even Dr. Ruben, we discuss with him and he decide, okay, go for MRI for brain and CT scan for spine, like this. Since we have both machines in the same place, our MRI just behind this wall, we can move from one examination to another in the same sedation immediately. And just keep in your mind, since we have a low field MRI, this procedure takes hours, usually.
If I can support that interesting thing that we usually say our low field MRI does not give as good images as high field. You can compensate for that a little bit with very long scan times,
yes.
But somebody has to pay for that. Yeah? I wouldn't say that it's the same quality, but you get pretty close to a high field MRI if you would scan that patient, let's say for 4 hours. But who wants to pay an MRI for 4 hours?
Doctor, we don't charge by time, and customer will not pay financially, but he will pay with animal health, because during 4 hours we shall keep.
It's usually very cold in
completely
this.
sedated.
Very cold in the MRI.
We cover with towels, we use, but anyway, it's always risk, it's always tricky, it's always challenge.
Okay.
Yeah, that's why it's important to know what the problem is to realize because of the savings.
Yes, and always try to do comprehensive, complete neurological examination to minimize area of interest. As less area we will scan, as less time it will take for the same quality of image.
And I would even support that by saying there's another argument why you need that neurolocalization, because let's explain a different way. If you take MRIs of our spines, I'm afraid that in the majority of us, we would find something. Yeah? Even though you may not know, because you feel healthy. But if you get sick now and we perform an MRI, who knows then if the lesion that has been there all the time is responsible for your problems now. So this dog, if we say the neurolocalization is in the peripheral nerve, it doesn't matter what we find here in the spine. It's probably not responsible for the clinical symptom. So the neurolocalization is not only important to shorten the area we are looking at, it's even important to avoid misinterpretations or overinterpretations of findings that are not relevant right now. And so there are two arguments really to localize the problem. And I pointed out several times yesterday that we really need that neurolocalization before you start to do any diagnostics. Otherwise you will have completely wrong diagnoses at the end. You're happy to find something and to call that the reason. Yeah? The worst thing would be that you do surgery on some abnormality that is not responsible for the symptoms the dog came in for. And the other thing, to say, if you can shorten the imaging time because we know the problem must be in that area, that is pretty good for the dog as well. It doesn't have to be under anesthesia for a long time.
Yeah, and also that's why we organized this training yesterday seminar. Invite doctor. Thank you very much for your visit, for your support. It's very valuable. Just to simplify your work, to reduce pressure and load and risk for your patient, and let you obtain much more information with at least available method of examination. Right now, just small like advertisement. We have low field MRI. With low field MRI, we can cover maximum about, let's say, maximum about 20 centimeters of length in one scan. We can go for several scans, but each place will take several sequences at least, and as much more quality we will obtain, as much more time it will take. With CT scan machine, with 16 slice CT scan, we can scan this dog from tip of nose to tip of tail in about 20 seconds. That's just keep in your mind and choose what is better for you, what is more acceptable, and always feel free to contact us, contact me. Mostly I'm responsible for this procedure. That's why contact me. We will find some solution which is optimal for patient and for you, and financial. Of course, if we will work together, we can reduce price. Because we charge customer by area, not
Okay, but my argument was that if you would have a scan that takes 4 or 5 hours, I guess you would start charging by time. So there's somehow a limitation what you can do time-wise. That's just the way it is, and that's why narrowing down to a certain area is very helpful.
Especially for MRI, if it's transversal scan, it takes a long time. Sagittal frontal, much or less shorter, but transversal usually much longer.
So the idea was actually that you would have the chance to perform neuro examination if you want to after under my supervision. Whenever I say that to an audience, usually nobody wants to do that because everybody's afraid of doing something wrong. It's up to you. That would be one option, or we have another dog as far as I know. We can have a look at together. Two
dogs with neurological.
Yeah, so you have to tell me, should we keep going the way we did it and I do the examination, we discuss that case?
Yes.
Or would you, yeah, okay.
Okay, let us remove this dog and need to please bring your vacuum cleaner. We will remove this hair. And also, because I hope
I'm not confusing you, but you have to weigh all those arguments. On one hand, you say, based on the breed, it should be type 2.
yes,
Yeah, but
on this patient
Yeah.
you shall expect. And as per owner, on the moment of referring to our hospital, dog was already paraplegic for about 2 to 3 weeks.
but
They try to resolve problem conservatively in other practice. That's why we cannot blame owner in this.
But the acute onset somehow does not fit with type 2. The acute onset would point to type 3 and 4, maybe, or type 1. Type 3 and 4 starts with a normal disc. Is it the normal 11-year-old dog? We don't know. This dog could even have a completely different disease we did not address yesterday. Acute onset in a large breed dog. There's a completely different disease. Sorry?
Is it fibrocardiac?
Yeah, fibrocardiolaginous embolism. So it's an acute occlusion of a blood vessel inside the spinal cord, and that happens in large breed dogs, usually middle-aged large breed dogs. And they have a typical onset of symptoms. Usually the owner reports that the dog is running around, is crying out in pain, and is suddenly paralyzed. You could say, can that not happen in intervertebral disc disease? It can, but usually that event was crying out in pain.
So unilateral muscle.
That would be the next thing, unilateral. Do you remember the Bordeaux dog I showed you yesterday, which could not move one rear limb? That dog did have fibrocardial venous embolism. Why is that not intervertebral disc disease? Most cases of intervertebral disc disease affect more or less both sides. It can be lateralized, but not lateralized to the degree that one limb is completely paralyzed and the other one is nearly normal. So if you see a very significant lateralization, that is usually not caused by disc disease, especially not by compressive disc disease. Try to imagine you are the spinal cord and you are living in a narrow structure. You cannot get away. And now something is pressing on your side. You will not only feel the pressure on this side, you are pushed against the wall on the other side as well. So you usually get bilateral problems. It might be worse on the side where the disc extrusion is, but the dog we have seen yesterday was nearly normal on one side and the other side could not be moved at all. So that does not fit with disc disease.
Okay, this dog, first dog was Dr. Branislav patient, and it was very quiet, very polite, very cooperative like Dr. Branislav. This dog is my patient, I'm so sorry, bastard like me. That's why we put muzzle.
So before we get him on the table, can we watch him a little bit moving around here?
Yeah.
Or?
Okay, may I show how it works when we admit it? This. Again.
Was there some conscious movement then? Was there some conscious movement then? Yeah, he couldn't stand up, but
No, it cannot.
but his legs weren't dragging
Just
behind
drag.
him, but they were
drag.
dragging in front of him, like he was able to move them forward.
Just on the front.
I couldn't say from the image. I usually try to lift them up in the rear and keep them moving to see if there's some remaining movement left.
Okay, sure. Should behave.
So I usually watch them for a while how they move around here to see how the gait looks like, because I'm assuming that there are still some residual deficits, but we start with the behavior, and that dog doesn't like his muscle. It's probably normal behavior as well. So does the dog respond in a way we expected from a dog?
It's about 1 month since surgery done.
Can we try to move a little bit that way?
Remove. Shadow. Come. Gather.
It's probably difficult to say. I sometimes go to a larger walking area with a dog where it can really move freely. So from what I see here, I couldn't say for sure if there is an abnormal gait, but I probably would go to a larger room to say that for sure. Okay, then we put him on the table.
It's abnormal. It has some residual. Okay, sure.
So we just ignore that he has been shaved there. For patients that have chronic problems with their limbs, sometimes you can actually see that the nails are shorter than they're supposed to be, or you may even see that on the top of the nails you see the scuffing lesions. That's why looking at the nails is sometimes helpful, but they look fine. So let's test the conscious proprioception again. the patient is supported, you carry the entire weight, and you carefully turn the paw around and see if it is performed the correction. And it's not resting on the left hand side.
Not
That works pretty well. And remember, reduced conscious proprioception is one of the first symptoms in the cascade of neurological deficits in dogs and cats with spinal cord disease. And if they recover, it's going the same way back. So if you have a patient that has normal conscious proprioception again, then you are pretty close to having a normal dog again. So I get the impression that there's maybe a mild difference between left and right. What type? What side?
Left. We operate on
Okay.
left side. Hemilaminectomy was performed on left side.
So if it is really true that the right side is slightly worse,
Yes.
what sometimes happens is if we perform a surgery from one side, we can only access one side. And it may actually be that some small amount of disc material remains, but that's acceptable. We cannot open up the patient on two sides. Yeah? So if this mild deficit is really...
Unless do laminectomy.
Yeah, but then you don't get underneath. Yeah? Let's see how he is responding here. Oh! So that is interesting because this dog does not allow us actually to place the paw because he's lifting it up. But we still want to perform the test. So one way is he really mean?
No, don't worry. We'll muzzle it.
I want to just to turn him a little bit. So one way would be if I want to test that limb, that I lift up with one hand the other limb, and sometimes that helps because now it doesn't help either, but sometimes it helps because he has to put weight on some type of limb. If that doesn't help either, there's a third option. What we are testing there is his ability to detect that his paw is in the wrong position. And I will just demonstrate it here on the rear limb. Sometimes we can place his paw on some paper sheet, and now we pull his paw away. And we are not testing the receptors now here, but we test the receptors in the upper part of the limb, in the joints that feel that the joint is in the wrong position. It's still the same tracks going to the brain, but it's a different way to perform this test. Just pull it to the side, and at some point he should place it back. The other option, I will try that, would be what I showed you in the cat yesterday, to place him against the table. It's important that you cover the eyes. He doesn't really do it on a real limb. It probably means that there are still, even though I thought it's completely normal, there might still be some minor deficits in the real limb.
Just maybe from this side.
So the question is, which test do you believe then? And I believe the result is at the end probably a mixture between both. But he's not so he's actually not supposed to see the table. Yeah?
Now also we see worse condition on the right side.
Yeah. One other option what we can do, at least we can try it on him. In order to see a left-right difference, if we perform this extender thrust reaction, where I lift him up and I put him back with his back feet on the table, and he's supposed to walk backwards. Let's see if that works. No, does not work at all in you. No, you are too scared. Okay, so sometimes that's the way it is. You cannot perform all tests. You are limited to the tests that you may even have a completely aggressive patient you cannot touch, then you are limited to what you can do. Yeah? But considering the severity of the symptoms he had before, he is relatively close to being normal again, but there are still some remaining deficits. Now we see if we can localize that to the area we have been thinking about, but we should still do a complete neuro exam. We start with the face again. And I do the test now, and you can already comment on the structures we are testing. Covering one eye. Careful not to touch that one here. So, what are the structures we are testing? Yeah, not trigeminal in this case because we don't touch them. Yeah, optical, brainstem, forebrain, facial nerve. Palpebral reflex. Trigeminal, yeah, brainstem, facial nerve. Nasal sensation. Trigeminal, brainstem, and forebrain. Corneal reflex. Can at least see the third eyelid.
Yeah.
Actually, we did not talk about what we are testing there in the first dog. Sensation, trigeminal, brainstem, and who is actually retracting the eye? No, unfortunately not. It would be too good because it moves the eye and it's not. It's the abducens, the sixth nerve. Yeah? Physiological nystagmus. Lift up the upper lid, move. Yeah, and you can do it up and down. It's usually not as easy to do it up and down, but it works that way as well. It's normal. Which nerves are we testing there? Sensory is vestibulocochlear, and now we need the formula with those three nerves. Yeah, 3, 4, and 6. Okay. Pathologic nystagmus. No movement of the head, and we observe the eye if there's any rhythmic moving. No, he's just looking around. Okay. Pupillary light reflex. From the nose to the lateral part of the eye, and if you get a constriction, go to the other side to see what happens there as well. And then we test the other side, and you can already think about the structures we are testing. Okay.
So
Optic nerve,
Chiasma.
chiasma, brainstem, and then it comes back through which nerve? You already said it, oculomotor nerve, yeah? Parasympathetic fibers of the oculomotor nerve. If you really want to see if there's no pathologic nystagmus, we could turn him around on his back, but we probably will try not to do that now. But we still have to do the segmental spinal reflexes. If we pull the limbs to us again, well, do you want to do that?
You want to put lateral?
Yeah.
Shadow.
Then I take the rear limbs.
Shadow. Just get.
Okay. That might actually be an example. This dog is somehow very tense, and I'm not sure if I'm able to perform a patellar tendon reflex. You will see. Sometimes if the limb is flexed, you do not know where the tendon is because everything feels like bone. It's very hard. If you extend the limb and palpate again, you will feel the dip of the tendon. So if he is laying here, you may not know where the tendon is. Extend the limb, palpate, there it's getting soft. So. What do you think about that?
Right.
Yeah, I'm not really impressed. It's more shaking. So I believe that might be the dog who is very excited or anxious. So let's test the lower limb. I'm not sure if you see that now. That looks much better. And we will see if you turn him around, if the same applies to that limb. Yeah? So, patellar tendon reflex, which nerve? Femoral nerve, and the femoral nerve comes from 4, 5, 6. You know, exactly. Cranial tibial reflex. It's a muscle belly reflex. The tip of the hammer and more power, and we take the tibia because that's supposed to move here. It's a pretty good reflex, at least not reduced. Might be increased, but as I said, for neurolocalization we look for reduced reflexes. Which nerve? Sciatic nerve, 6, 7, and sacral segments. Flexor reflex. It takes the skin here between, and that's pretty strong. Maybe even better than in the dog we had before. We test laterally, and we test medially, and it's great. Laterally, those 3 ditches are sensory innervated by sciatic nerve. The response is sciatic nerve. Medially, the sensory input goes to the spinal cord through femoral nerve. The response comes back through sciatic nerve. So that's pretty normal here. Let's see the front limb. Extensor carpi reflex. Start with a flexed carpus by flexing the elbow. Muscle reflex. Tip of the hammer, a little bit more power. It's there. Spinal cord segment C6, T2. Flexor reflex, that works pretty well. Can we turn him around on the other side? Shut up.
Get up. Get up.
You have pretty short leg Labradors here.
It's a cross. It's mixed. Not pedigree.
So, we know that this limb didn't have a pretty good patellar tendon reflex when it was laying down. Let's see how it works here if it is on the upper side.
As owner represent this dog as Labrador, and I didn't want to insult them. That's
okay.
Why.
So if you can maybe let the lower limb go for a moment. I'm not sure if you can see that now, but it's better than it was. Sometimes it helps just testing the lower limb. Patellar tendon reflex is pretty good. Which nerve? Which spinal cord segments? Femoral nerve 4, 5, 6. You know that it gets a reflex. You don't have to think about it anymore. Yeah? Cranial tibial. It's a muscle. Tip of the hammer. And a little bit more power, and there it is. Which nerve? Okay. Flexor reflex works nicely there as well. Extensor carpi, flex the elbow, and that way you flex the carpus. Muscle reflex, tip of the hammer. Pretty good reflex. Spinal cord segment C6, T2. Flexor reflex, and there's appropriate power here, comparing with the other dog. Okay. Do we believe that that dog had a neurological problem? Besides the fact that you know it has surgery, but does it still have neurological problems?
Yes.
Yeah, very mild in the real and proprioceptive deficits. Does it appear to, if you want to localize it, you don't see the scar, if you want to localize it, do you believe it's a peripheral nervous system disease?
No, because the muscle tone is pretty good.
The muscle tone is pretty good. It's not only one limb that is affected, and it's not that all 4 limbs are affected. So those criteria do not apply as well. Yeah, you're right, but let's still go the next step. Does anything indicate that there's a problem in the head? No. And then we get to the spinal cord, and I said 2 questions for neurolocalization of the spinal cord. The first question was, are only rear limbs affected, or is it front and rear? Because if it is only rear limbs, it has to be from here caudally. If it is front and rear, it has to be here. How does it look like in that dog? Rear limbs. So there are 2 spinal cord segments left where the problem can be, which are the segments T3, L3 and L4, S3. Now we have normal segmental spinal reflexes, and those reflexes test the segment we have here. If the reflexes are normal, this area has to be normal. It's T3 actually. And you did the surgery on the right space.
Yeah, thank you.
Yeah.
Because until now I still doubt.
So whatever this dog may have on the images here in this area, it's not relevant.
Nothing.
Yeah, it's not important right now. So
Panicular.
yeah. Thanks. I don't want to test for pain because I know that.
Do they lose that post surgery? Just torn away.
It could actually be because sometimes you injure the nerves, but what happens is actually, I'm not sure who asked that yesterday. If you, yeah, exactly, you may only lose it in the area where you have the surgery. So if you get a cut off now, it's not working and it's working, then it's probably caused by the disease. If you get just a small area where you lose it, that might be caused by injury to the spinal nerve during surgery, which sometimes cannot be avoided in order to decompress the spinal cord.
Usually, if though situation happen, you can observe some weakness on abdominal wall on surgical side.
If you are cutting the panniculus muscle, so you have to, this is gone.
Actually, the panniculus muscle itself, which is the muscle in the skin here, that's more retracted. You're not really cutting through there, since the skin incision is here. You are cutting into the muscles that are close to the spine, the multifidi muscle, but those are not responsible for the panniculus reflex. So you're not really injuring the muscle that is responsible for the twitch.
I haven't talked about anal tone.
Yeah,
And scrotum.
yeah, so I did not talk about that because it's really, it's a special subgroup of patients where that might be a problem. And but since you mentioned that, yes, the anal tone becomes important with lesions in the area of the sacrum. Well, I should rephrase that, with problems of the sacral spinal cord segments. Why did I rephrase that? Can I have the table once more? Make a little drawing there. We neurologists talk about, as I said, spinal cord segments, but we have to be aware where those spinal cord segments are. Especially in the sacral area, there is a discrepancy, a significant discrepancy, thank you, between vertebral bodies and the spinal cord segments. So let's, and that's the sacrum here. That's L7, L6, L5. The sacral spinal cord segments, which you would probably expect somewhere in this area, they are usually located somewhere in the area of L5, L6. So the spinal cord ends somewhere here, and then you have the sacral nerves going further. How can you memorize that? The sacral spinal cord segments are in a mid-sized dog in the area of the 5th lumbar vertebra, because the S looks a little bit similar like a 5. The smaller the patient is, the more that shifts caudally, and the larger the patient is, the further it shifts cranially. So in a Great Dane, the sacral segments may already start at L4. So if we do our neurologic examination and we localize that to sacral spinal cord segments, then if you take an X-ray or an MRI or CT, we are not looking for a lesion in the sacral area, but further cranially. So much as introduction. Where does that, what consequences can that have if you have injuries or diseases of your sacral spinal segments? You can have a loss of anal tone, a loss of anal reflex. So one easy thing to test that would be to touch the perianal area, and one of two things can happen. either the patient wants to clamp down the tail, or you actually see the contraction. Sometimes the contraction is very mild, and if you're not sure, you have to do something that is a little bit dirty. You have to stick a finger in. Obviously take a glove, but
We have gloves.
you stick a finger in, and once you have your finger in, now you touch the perianal area, and you may actually feel the constriction around your finger, much better than you see it. One other way to elicit this reflex is actually to press on the glans penis, and I will do it in a second, and I say now, and then it's a moment where I'm pressing, and you have to observe the anus. And we'll turn them around so that you can see it as well. Now. Now. It's not really constriction, but there's some reaction there. Maybe you can turn them around once more. Now. And you can do the same with a female dog if you put some pressure on the vulva. It's basically testing the pudendal and the pelvic nerve and the sacral spinal cord segments. And that may be a problem with lumbosacral disease sometimes. Yeah. You wanted to show the images of that?
Yeah, I just want to show how severe lesion it was. Huh?
Stanislas, how long after the injury you were actually operated on?
I don't know. As per owner, this transversal view, CT scan. This sagittal. And this dorsal. It's more than 2/3 of vertebral space is occupied by.
Can you try to guess what type of disc disease that is based on the images? It's white on CT, so it's somehow mineralized, otherwise it would not be white.
And this on 3D reconstruction.
So if it is mineralized, that means before the disc extrusion developed, it was already a degenerated disc. That leaves us with two types that could potentially be the case. Type 1 and type 2, because the other types start from a normal disc. Now, it was acute, not a chronic progress. Type 2 is chronic, so it's most likely type 1.
It's written on type. Hansen one.
Okay. Any question about this one?
So,
So
you
how
don't,
old is the dog? How old is the dog?
11.
Oh, okay.
Quite.
and between the acute injury and the surgery, we don't know how long.
As per owner, about 2-3 weeks. But you know how to trust on owner information.
So do you think that the earlier surgery would have made a difference on the outcome?
Outcome's pretty good.
Yeah.
You want better?
No, I'm talking in general.
So in general, I believe if you feel that surgery is an option, then the earlier you do it, the better. And I mean, we just have to imagine it would be us. Yeah? We probably would have to have surgery relatively soon.
And according to our criteria, we have in our hospital, this dog was non-ambulatory. And if we want to do surgery, then
The earlier the better.
the earlier the better.
But are they, because when I did my internship, there was like statistics with the percentages on the time we do the surgery with the
Oh, you should have gone yesterday.
outcomes.
So there are only studies so far that connected the outcome to deep pain negative patients. We do not, interestingly, we do not have really studies comparing in dogs with still intact voluntary motor function if time has influence on the prognosis. We just don't know. The only studies we are looking at deep pain perception or not. I said yesterday that when I had my neurological training, we had that saying deep pain negative for more than 24 hours and the prognosis drops dramatically to something of 5 to 10%. That picture has changed in the last years. We do not really know if that time frame is so crucial anymore. You still have a chance of 50 to 60% of recovering your gait, even in deep pain negative patients. We do not know if there is a cutoff after 3 or 4 days, but it doesn't seem to be the 24-hour cutoff.
This material, which is
More on the right.
Then
this,
surgery
I don't know. This, I think it's Karen handkerchief. Yeah, Karen. This, your handkerchief.
Okay. Yeah, we had actually planned 2 hours for this, and I'm afraid that this time is over, as far as I know.
Yeah.
Are there any questions either about the day today or what we discussed yesterday? The last chance to hear me saying once more, I don't know.
With the arthritic dogs that have orthopedic injuries as well, how much does that affect your neurological exam?
That's a tricky question, because I have to contradict myself now. I said yesterday and today, if you have loss of conscious proprioception, it means it's a neurological disease. And that statement is correct. But if you have mildly reduced or delayed conscious proprioception, that may actually happen with severe hip dysplasia, because I do not want to move
I
my
prefer
limb.
to stay like this.
Yeah. So if you have slightly delayed conscious proprioception only in the rear limbs, in a breed that is prone to have hip dysplasia, I probably would take X-rays to see if there's severe hip dysplasia. If it's only mild type, it does not delay your conscious proprioception. But if you have severe arthritic changes there, that could be the reason why you have a slight delay of conscious proprioception.
Okay. Do you want to say?
Yeah, as I said,
Sure.
we are actually already at our time frame, because I'm expected to be back. I was told 9 to 11.
Mhm.
Yeah.
Mhm.
Maybe just
Still
one
yours.
question I wasn't here yesterday, and maybe that was when you answered with the anesthetic protocol for hallucinations.
I'm not aware that there is a special recommendation. So basically, it's done whatever is routine in the hospital where you are. So there are no recommendations. There are recommendations for brain surgeries, but not for spinal surgeries, as far as I know. So what are we using? We have an anesthetic department who does anesthesia. So I even don't care what they do.
The best anesthesia, what you are familiar with.
However, at night, in an emergency shift, I am the anesthetist for my patient. So what I do at night, I use a pre-medication with diazepam and levometadone. I'm not sure if that is available here. And then I induce it with a mixture of psilocybin and ketamine. and then they get intubated, and we use isoflurane for inhalation.
Any local anesthetic?
No, I'm not doing this, no. And my impression is when you have done a good surgery, then pretty soon after surgery they're not painful anymore. So, no, I'm just not using local anesthetics, no. Okay, yeah, then thanks for being here.
Thank you.
I hope that you could take little tiny pieces of information that you can use maybe that you have to use them in the next 1 to 2 weeks. If you don't do that, then you will forget more and more of that stuff. So just look for the next neuro patient, and if a dog comes in just for vaccination, do a neuro exam and find something potential. Yeah. It's actually important that you do examination on a few normal patients. Just by knowing what is normal, you are able to find something abnormal. Okay.
Thank you very much.
Thank you. Yeah.